everyone. I am Dagny Medical Director at Envision Eye Centers in Rolling Heights, California. And today I am joined by Dr. Eric Rosenberg. He specializes in cornea and external disease at Site MD in Babylon, New York. And he's also an assistant professor at New York Medical College in Valhalla. Hi, Eric. Welcome.
Thanks for having me, Dagny. What a great podcast this is, and how excited I am to join you here today.
Awesome. It's an honor to have you. So on this episode, we're going to talk about an exciting topic, the latest information pertaining to digital integration of medical and surgical eye care, which I know is a passion of yours. So let's just start right off. What are some of the new digital tools available for screening and detecting ocular disease?
Wow, that's a great question, and I think it's a passion of both of ours, if I'm not mistaken. You know, we both really like this realm, and it's a really fun one to talk about. For the digital tools available, there's so many. The depth and breadth of digital technologies that are coming out of the woodwork, being put at our doorstep, right, to be able to utilize in clinical practice are numerous, and oftentimes it can be a little bit cumbersome and over inundated with like information of what's coming out, how it's going to help. We've always had digital tools in ophthalmology, OCT, topography, tomography, fundus autofluorescence. We've always adopted technology as soon as it's coming out the door, and AI and these new digital tools are no different. So at the moment, we have two fully autonomous AI systems for detecting diabetic retinopathy that operate without human oversight. That's like huge, right? We've developed a software package that can recognize DR. I believe it's with close to 87% sensitivity, 90% specificity. It's able to kind of do our job a little bit for us, or at least help us in doing it. So that's one of the big things that people are worried about with AI, right? Artificial intelligence. But I think Yannick Leiderman or Ted Lang coined it best, where we should probably be calling it augmented intelligence. It doesn't do our job for us, right? But it helps us to do our jobs. Now, there's other products being developed right now for glaucoma screening, for cataract screening. You can just imagine a world where somebody's going to put a kiosk, in a Walmart or a Target or a CVS, where you just put your head inside and it can do the majority of the screening that we do in our office. I struggle, and maybe you can chime in a little bit here to help me identify some of the real groundbreaking devices that are coming up, because they're just also novel, they're also unique, and sometimes we can lose the forest for the trees with the adoption of some of these technologies. And I think what has surgeons a little bit more turned off is because we've become, the operator for all these technologies, and everything kind of comes back to us. So, the interoperability of it, I think, is going to be clutch and key, because we need to start using technology to deal with technology, if that makes sense. How do you identify what's going to break through? Because I know you're strong in this.
I agree with you completely. Like ophthalmology is such a visual and digital field already. It just makes sense that our field would be the one to advance in that field of AI and like new digital technology. And I see us heading towards like two fronts. One, which you mentioned, which was basically improving like remote screening of ocular diseases, either remotely from home or like they've done so well with diabetic retinopathy screening, setting up in the pharmacies, kind of public venues. But the other area that I think that we're heading is even in our practices itself, I think sort of maximizing efficiency of some of those diagnostics and making the experience better for our patients. So some of the companies that I work with, they're actually working on wearable diagnostics headsets. And I think we see this a lot. I mean, you saw Apple's like augmented reality virtual headset. I feel like we're all headed that direction. But anyways, with this headset, you can do numerous diagnostic tests, including, visual field testing for glaucoma, hopefully in the future, topography, refraction. So instead of shuffling the patient from one room to the next, they can literally sit in one room, wear a headset, and the diagnostic tests come to them. And I really think that improves the patient experience and also maximizes kind of like practice efficiency and workflow, and kind of takes some of the burden off of our technicians as well. So that's another area that I see a lot of innovation in this space.
And I think that our partners, in ophthalmology need to understand the difference between synchronous and asynchronous modalities that exist for our patients and for us. Oftentimes, when they come to our office, right, that's a synchronous event. You see them, you input their information into the chart, you do the testing, you have that discussion about it. But then when we have these asynchronous platforms that are going to exist, like telemedicine, telehealth, the kiosks, other things like that, there's going to be other time points that didn't previously exist in the patient journey across the diagnostics and the treatment that we didn't have before. So there's a sentiment out there that we shouldn't make technology change to us. We should start considering changing to the technologies too. And in doing so, I think, we'll all be better for it because we can start advancing medicine in ways that we weren't able to advance it before and how we think about it, which is really exciting, obviously.
We talked a little bit about AI and how we can use that for sort of diagnostics. You're a fantastic cataract surgeon. Let's talk a little bit more about how we're using AI to transform medical and surgical eye care, specifically for cataract surgery. How do you see AI playing a role for cataract?
Yeah, I think that this is going to be a huge one, in my personal opinion, and it leads to the digital visualization component of what I've been pressing on a little bit lately. All components of a patient's journey through the cataract evaluation and then after the cataract procedure is all documented. It's documented on the EHR. We do OCT max, we do pentacams, we do biometry measurements. We'll do RNFLs. We'll do all that stuff. It exists in a digital realm. Granted, to pull out the data and the metadata tags are not ubiquitous across the board. Nonetheless, they still exist in ones and zeros, right? And then on the back end, it's the same thing. We're documenting, patient visual acuity outcomes, the satisfaction rates, other things like that. So there's a couple, companies that have identified that the patient goes through a journey, and that we can start leveraging that data to really understand, what we should be doing intraoperatively. Now, intraoperatively, until we had digital visualization, there was no in OR capabilities of being a synonymous ubiquitous system. There was no way to transfer data across to the OR and then back out. These digital visualization suites are the first time we have a digital presence in the OR, and it was the missing link to a lot of what we do. And we're going to see AI have a huge play in this, because what we're going to be able to do is leverage these big data sets that we have on these patients that we already have and we've already done, to be able to help us, whether it's calculating, intraocular measurements, whether it's changing phaco parameters on us, studying the fluid dynamics of the system. And if it senses a turbulent situation, or maybe it senses the phaco tip is a little bit deep, it either gives you a warning or changes your phaco parameters to make it a safer surgery for you. We're going to start seeing all these applications that not just exist within the OR, but across the spectrum. Ray Pro is one of those suites, right, that goes across, and they're trying to identify what patient variable outcomes what patient outcomes are, and kind of objectivize them, to be able to understand what the lenses are best. It's not specific to their lenses. It's not specific to anyone's lenses. It's just, okay, I did this number of lenses. These are my patient reported outcomes. This is it in metrics. How am I really doing with these particular lenses? And again, using AI-backed algorithms and ML-backed algorithms, will be able to help us in selecting appropriate lenses for appropriate people, not just, oh, this one's an engineer, this one's a pilot, I'm not doing a multifocal in them, right? Which, is a broad blanket statement. It's a broad stroke, which we want to try to avoid if we can, even though it may hold true for the vast majority of them. But I have a pilot who loves their multifocal. They would be miserable without it. I'm hoping, and we're starting to see, that these technologies, especially in cataract surgery, are really going to help transform the landscape of what it is that we do in practice.
Yeah, again, I think you really emphasized two of the things that I see are really big in this space. Number one is helping us better select or better match the best IOL to each patient. And I think this is especially important with premium IOLs if you're in the refractive cataract surgery space. Like you kind of said, right now we're just picking IOLs based on our own gut feeling as a surgeon, our own experience, N of one. But honestly, there's so much data that we could be using, big data, machine learning, to better optimize our IOL selection to maximize, patient satisfaction and success with a particular IOL. So I'm also working with a company. I guess there's a lot of companies working on this, but I'm also working with one that is creating an algorithm. So utilizing all the inputs that we have. So for example, like you mentioned, the patient's occupation, their lifestyle, their personality, their habits, their desires, and combining that with the optics of their eye, what their topography shows, the higher order aberrations, things like that, and matching it to the optics of each IOL type, whether it's EDOF, trifocal, and it kind of gives you a numerical score of, which IOL this patient would do the best for. And they rank it based on different categories, nighttime driving, distance vision, near vision, spectacle independence. And I think that's going to be the future of how we're going to practice with AI as refractive cataract surgeons. Like, we need more help in this arena. We need like evidence-based decision-making rather than just going by our gut, which is kind of what we've been doing all this time. But it would be very cool to be able to pick up on those nuances where, hey, it might work in this instance for this particular patient, right? And the other part that you mentioned that's really exciting is the fact that it can make us a better surgeon, right? Using AI to kind of adjust, like you mentioned, fluidics or different parameters during surgery. So we have already a lot of devices that we currently use to optimize our outcomes, to how to align our toric lenses, how to select the best power with intraoperative aberrometry. But I think collecting big data and using AI to optimize surgical parameters, and some femtosecond lasers are already doing this. They're using the grade of the cataract, different features of the cataract to program the femto, and then ultimately the phacoemulsification device to tailor the surgery to that patient's cataract and to optimize outcomes in that way. So those are the areas that I think AI is going to make us even better cataract surgeons.
I love that. With the new Ingenuity 1.5 software, it does iris registration, right? We can identify the correct patient, procedure, site positioning just by putting the camera over the eye. Now, you have to imagine that, in the future, it's just going to be a camera. The optics are so good already. We're going to use digital enhancement and digital visualization in ways that we couldn't have imagined. And with the traditional operating microscope, we're bounded by the laws of visible light and physics and optics. When you start adding cameras and COMS sensors and other sensors, you're going to be able to see things that you didn't previously see, with modalities that we didn't previously have at our disposal, right? And I think in there, when we're going back to kind of refractive surgery, we'll have a modality that's able to know where the femto placed its LRIs with the relative cyclotorsion that occurred on that particular eye, and maybe have you change where you're going to do your main wound incision just because it knows that you're going to have a little bit better of a refractive based outcome by moving the main 2-4 incision 5 degrees inferiorly or whatever. You're going to have somebody, not somebody over your shoulder, but you'll have somebody with you, right? Helping to guide where, how great is that?
Yeah, the precision of this is going to be unprecedented. So this kind of brings us to the next question. And, this is a common issue that we face as cataract surgeons is how do we hit that refractive outcome, right? I think the most common reason for patient dissatisfaction, especially with premium IOLs, is still a residual refractive error. So how are we using AI to better predict refractive outcomes?
That's a great one. And I think we can look at our partners who have started creating AI-based IOL algorithms. There's one company in particular who's already announced and released it. I have nothing to do with it, but it's really impressive what they've done. And they built this model that has to do with paraaxial ray tracing, and they use a database of, I think, 500,000 simulated eye models that it used to predict the IOL power. So it uses preoperative biometry, anterior chamber depth, postoperative IOL positioned, effective lens, but ELP. It helps in helping you identify which is the correct power and lens to use at the time of cataract surgery, kind of like what you were mentioning before in terms of those refractive outcomes. Now, when we're talking about hitting the spherical equivalent, then yes, that's going to be super helpful. But with hitting refractive outcomes, meaning more stigmatism-based correction, then exactly that, right? We're going to have intelligent femtosecond lasers that are able to match up to the preoperative data, understand that the eye has cyclorotated X number of degrees, and be able to put those arcuates. I mean, a felt pen, which I think the majority of us use, to be honest, is off by 2 to 3 degrees just at base. I mean, that's how thick the felt tip pen is. So you're going to be off there a little bit. And, how accurate is really using a pen or really any other modality other than true iris registration and true scleral vessel fixation points to be able to do those LRIs. Hopefully in the future, there's going to be a little bit more freedom on being able to do a lot more refractive based outcomes for our patients. And I think some of these technologies are going to help with that too. There's not a surgeon that I know alive that doesn't want their patient to have the best possible visual acuity outcome at the end of the day.
I really think that more surgeons are going to move towards using an AI-based IOL lens power calculator. We've come a long way from the first generation IOL formulas. I think most of us use the fourth generation ones now, Barrett being one of the most popular ones. But there are actually a lot of quite a few modern day publicly accessible AI-based IOL formulas that are out there. And I don't think a lot of surgeons know about them. So I actually took a look to see if I can come up with a comprehensive list, but there's quite a few. The Hill RBF is actually based on large data sets and has AI incorporated, as well as the EVO, Kane, the Pearl, the Hoffer QST, I guess is the next version, the Lattice Super 2.0, and also the one that you talked about, Eric, in the beginning, the one a large manufacturer that's using basically a large database, like 500,000 of their data sets, right, from current cataract surgeons. They're using that big data and combing through in order to get you more precise IOL outcomes than ever before. And they said they're using 16,000 different IOL parameters to come up with this prediction. Because if you just rely on your surgeon a constant, you are neglecting many of the variables that play a part in the final, refractive outcome. Because even within the same IOL brand, you have differences between the curvature of the lens, the thickness of lens from one power to the next. And you're operating on different eyes all the time, short eyes, long eyes. How could you possibly use the same A constant for all of those, right? So it's great that this AI calculator is being backed or powered by hundreds of thousands of data sets. And the great thing about these AI calculators is that it's constantly learning and improving, right? So it's going to continue to collect more data. It's going to continue to put out even more precise data over time. So just get better.
So that's a really great point, and one that I think a lot of people are going to overlook when it comes to the AI-backed IOL calculators. A lot of times in clinical practice, we have similar demographics, similar patient populations. There's a lot more homogeneity within a single practice. But in working with our industry partners with some of these programs, which I don't think that there's an ophthalmologist in our community that would be able to just do that alone, right? We've come to a point, I think, in medicine where we know that we need to work together with PhDs, with scientists, with engineers to be able to solve some of these problems. And IOL specifically, everybody gets cataract surgery, right? There's not a population that is left out of that mix. And one of the previous problems with a lot of the AI data sets was just the people they recruited in order to do the analysis on. So patient populations were typically more diverse, than those that were commonly used in those smaller data sets. Cataract surgery really runs the gamut, and I think it's going to be, and provide us with high fidelity data where it's going to be applicable to all genders, races, ethnicities, everything. And that's what makes everybody unique, right? And choosing the IOL IOL power can sometimes be tricky because maybe the ELP is different on this person. Maybe, the amount of higher order aberrations is higher in this one and this particular culture, right? There's a lot of stuff that we haven't teased out because it's just too cumbersome to do so. And leveraging AI is going to help us in doing some of these repetitive tasks that maybe were too onerous on us in generations past, right? To be able to, really tease out the true differences that existed, to be able to provide the best possible care going forward. So it is really exciting that cataract surgery is literally for everybody, right? There's nobody left out of that mix. Everybody gets cataracts, everybody has lenses, and we're going to have pretty good data sets that govern that going forward too.
We talked a little bit about IOL selection. How about using AI for post-op complications? What are your thoughts about that? How can it help us there?
I'm hoping more that it helps us prevent complications, right?
So that's exactly what I was thinking too. I mean, we're trying to avoid a huge refractive miss, right? Which I think is a complication in many patients' eyes.
Absolutely. And do I think it's going to happen? The answer is yes, right? This is medicine. No matter what you do to it, no matter how many sciences you apply to it, no matter what, there's going to still be an art to medicine that is never going to be taken away. I think we're going to, and depends on how you define complication, right? Did you go through the posterior capsule? Did you encounter vitreous? Did you cause an iridodialysis or a cleft, while doing a MIGS? There are plenty of things, and judging by what the complications are now, I think it's on us as a group of ophthalmologists to be able to help the engineers and the data scientists identify ways that we can make the surgery safer, and by using some of these new tools in order to do so. In digital visualization, the system I use has something called MIGS mode, and it uses high gamma, high contrast sensitivity and digital enhancement of the canal of Schlemm, and it pops out to me like a Christmas tree. As soon as I put the gonio on, it's clear as day, and I go under high mag, which with the digital system, I can go in higher mag than I can with the traditional optics anyway. And really doing MIGS is nothing anymore. I felt it used to be the hardest part of MIGS was the visualization, right? Like anything else in surgery, if you can see, you can do. But if you're having trouble seeing, that's where you're always going to get into the complications. It's why we fear small pupils. It's why we fear synechiolisis, synechiae to the posterior capsule. All these things, prevent us from being able to visualize, which then, induce complication. When we can leverage these technologies to help us visualize the things that we want to see, we're no longer constricted by the bounds of traditional physics and optics. We've passed that. It's truly a revolutionary product, in the sense that in of itself, we're able to see better. And now you're able to string it along with everything else, preoperatively, intraoperatively, postoperatively. Everything's going to be able to, talk to one another, if you want to look at it that way, to help us prevent these complications, which inevitably happen to everybody, right? I don't think anybody's immune to that.
I totally agree with you. I think there's a lot we can do with AI to prevent post-op complications. I think even just creating some algorithms that would help to decrease, the probability of having a particular outcome. So for example, worsening macular edema in a diabetic, right? Which diabetics should get anti-VEGF ahead of time? Maybe some patients need subconscious analog, things like that, just helping us reduce common, potentially common risks and adverse events that could happen with particular patient populations. So awesome. So we talked a little bit about this in the beginning, but let's dive a little deeper into telescreening. So, we all came out of that pandemic in which I think telescreening really got a lot of attention, and actually it really pushed our technology forward, especially with diabetic retinopathy screening, especially for areas, with limited access to care. So can you talk a little bit about some of the newer digital tools that we have for our patients who may not have regular access to eye care, for managing ocular diseases? For example, home OCTs, or even like virtual retinal imaging clinics. Like, let's hear the latest on that.
So that's great. Yeah, no, the home OCTs are wild, wild devices. Something I never thought I'd even see in my career that exists. And again, it goes back to the synchronous versus asynchronous care. that we should start thinking about for our patients. Glaucoma is a perfect example. Somebody's a glaucoma suspect, or maybe they're an ocular hypertensive. They're coming to the office every 4 months just to check a pressure at one random point in time, even though we know it's diurnal, even though we know that there's fluctuations. What do the fluctuations mean? Maybe that's important, right? What is it at nighttime? What is it during the day? They have essentially Hall effect sensors embedded into contact lenses that help understand, the strain on the corneal surface, essentially assuming IOP measurements. So we're able to use contact lenses to measure IOP, consistently over a period of time. The telehealth aspect of it, I think, is really going to be extremely important going into the future. And one thing that I saw at the last ASCRS that I was really excited about are 3D digital slit lamps. I was very, very excited to see that, because I think the one thing that we lose, right, with telehealth and telemedicine, especially as an ophthalmologist, is the two-dimensionality of it. Nothing we do is in 2D. Nothing. Everything we do has stereo to it. These 3D digital slit lamps kind of flip the script on what we can do and what we're going to be able to do, and the number of patients we're going to be able to reach. There was a group that actually built a 3D slit lamp, used a drone to carry it into a ward torn area, be able to do telemedicine war front exams with an ophthalmologist that was maybe in a different country, and then be able to guide them on how to handle it and what to do, which is wild, right? You're able to provide access and care to areas you were previously unable to reach. I think telescreening and telehealth is going to be a really important and revolutionary component to ophthalmology going into the future. And I'm really excited to see what people do with it. Grayson Armstrong, for example, he's a huge advocate for it. He's a huge producer. He makes a brilliant kid. It's going to be something that we integrate into the future. There's no doubt about it.
That is so cool. I love that our technology is headed that way to make this possible, because remember during the pandemic, we would see some of our patients remotely through Zoom, but it's like there's only so much you can do through that web camera, and I don't really know your eye pressure, but it's so great hearing that there's so much progress being made on that front, where there's like 3D slit lamp imaging and all of these innovations that's going to make telemedicine more possible, more accessible for ophthalmology. So love hearing about that. So, we talked about a lot of technologies today, and people are always wondering or scared that AI technology is going to replace the doctor, the surgeon, the human mind, right? So what are your thoughts on that? And what are some of the drawbacks to be aware of when using any new digital technology in eye care?
All technology we know has its limitations, and it has its drawbacks. We were just talking about one before where, depending on the curated data, it's going to have its own inherent and innate bias. We need to make sure that the data that we get is, number one, clean, right? It needs to be, good, useful information, not just stuff that's plugged in haphazardly, right, on the system, no thought about it, and then somehow utilized for actual data processing. So everybody's favorite adage is garbage in, garbage out, right? We need to make sure that metadata comes through, right? Not just, the visual acuity, but what was the patient's age, ethnicity, sex. This helps us with the performance analysis and being able to do, some of the AI and ML applications. We have that lack of standardization that already exists. And, I think that's where the Digital Ophthalmic Society, and now what is, just created, is the Digital Committee at ASCRS, which it's turned into, and now being led by John Hovhanessian. That's where it comes into play. And, when we start talking about AI, we have unsupervised models and we have supervised models. The unsupervised models are a lot more susceptible to something called drift. And in doing that, because you don't have a human supervising it, it can slowly, deviate from its original task, if you will, where something was seen as positive before is no longer seen as positive, just because of how it's processing and how it's going through its self-learning algorithm. So we have to understand what the limits of the technology are, and we have to be, astute to it.
Yeah, I think at the end of the day, you as a surgeon will always have the final say, right? But it's nice. It sure is nice to have all this data to support your final decision and all these brilliant minds. It's not just you N of one anymore, right? AI really brings everyone together as a community, as you said, and power is through numbers, right? So I'm very excited. Thank you for your leadership in spearheading digital society and digital day at ASCRS. So you're really leading that forefront.
Oh, thank you. It's all of us. And now it's led by John Hovedesian, so I no longer have to bear that burden. So thank you, John, if you're listening to this podcast.
This has been a great conversation. I feel like AI has really helped bring us together. We keep talking about accessibility, and in doing so, it's helping us to educate the next generation and also improve outcomes for our patients in so many different ways. So thank you so much, Dr. Rosenberg, for this excellent discussion. Thank you all for listening. Please remember to take the post-test and evaluation to receive CME credit, and do tune in for additional episodes within the podcast series. Thank you, everyone.